Am I audible? Is my screen visible? Okay. So today's session will be assessment of nutritional status. It's on page number 286, chapter 26. Assessment of nutritional status. So starting with malnutrition, what do you mean by malnutrition? So malnutrition, as defined by WHO, World Health Organization, is a cellular imbalance between the supply of nutrients and the energy and the body's demand for them to ensure growth, maintenance, and specific function. When the supply and demand of nutrients and energy within your body is imbalanced, that leads to malnutrition. Okay. So there are two major categories of malnutrition. One is undernutrition and another is overnutrition or overweight. Okay. So undernutrition, it includes stunting, low height for the age, wasting, muscle wasting, body mass wasting, which means low weight for the height, underweight, low weight for the age, micronutrient deficiencies, insufficiency, okay, lack of important nutrient, vitamins and minerals are absent. Okay, so the am I audible? Is the screen visible now? Am I audible? Is the screen visible now? Okay, so these were the examples of undernutrition, overweight or obesity, diet-related non-communicable diseases like coronary heart diseases, stroke, diabetes, cancer. They also can be related to malnutrition, which is overnutrition. Again, that is an imbalance between the nutrients, energy requirement of the body. So coming to the assessment of nutritional status, A, B, C, D, E, F, G. This is the mnemonic which you can use to identify the 7 different ways in which nutritional status can be assessed. So A stands for anthropometry or oxology, taking measurements. Okay, it's like it's a gold standard of evaluating the nutritional status. Okay, height, weight, age, based on all these things. If the child comes under the category of healthy or unhealthy or not, we will categorize it out. So that is anthropometry or oxology. Then we have biochemical or lab indicator, blood test. Okay, they all come under this category based on the reference value micronutrient deficiencies. It can be found out using this step. Then we have clinical features. In clinical features, if the child has growth retardation, stunting, dwarfing, dullness, color change on the skin, rashes, frequent infection, color change of the hair, edema. Okay, these all are clinical features based on which the child can be classified into types of malnutrition. Dietary evaluation, seeing that and observing what all the child eats, keeping a track of it. Okay, that comes under dietary evaluation. The epidemiological and ecological factor, sociology, poverty, urbanization, infections prevalent in the public health. These all comes under epidemiological factors. Then functional assessment, motor development, neural development, emotional development, intelligent quotient. Okay, these all comes under functional assessment. How the child's brain and body movements are aligned. Then growth monitoring till the age of 5. Okay, uh, all the milestones have to be monitored. It has to be graphed and checked out in the mother and child health card. Coming to anthropometric assessment oxology, there are different tools. We'll discuss each of them. One is weight for age. So we have Salter type scale in which there are like pant-like structure into which you put the infant or baby in and it will weigh how much the baby is weighing or how much the infant is weighing. Then we have double weighing technique in which the mother is weighed first, okay, because child usually will create a lot of fuss. He will not sit still. So you will not get the exact weight of the child. So a double weighing method, first you see what is the weight of the mother and immediately after it, you give the child to the mother. The child will hold on to the child, the mother will hold on to the child and take the weight again. Subtract mother's weight from the second way, answer. You will get the child's weight. Next we have is height for age. So height, if it is an infant or a toddler who has not attained walking by their own level, so for them length is covered. Okay, in a lying down position, the children's length will be covered. Once the child stands up or child starts to walk, height will be measured. 1 minute. The child should be barefooted and while taking the height, shoulders should touch the wall, buttock should touch the wall, occiput of the skull will also touch the wall. The child will look straight ahead, chin should be up, okay, and that's how you calculate the height of the child. Then weight for height. This is also one of the best indicator. If it can also give you an indication that if the child is normal or wasted. Okay, so it's available for boys and girls. Two different charts are available, centile and Z-score chart. For children who are less than 5 years of age. Then mid upper arm circumference. Between 6 to 60 months, this parameter can be checked. So you have to first measure the length of the upper arm, just the upper arm from shoulder to elbow, divide it, find the midpoint, and in that midpoint, find the circumference. That is the mid upper arm circumference. So if the reading is less than, if well-nourished children will have a reading of 16.5 to 17. Okay, and if the reading is less than or more than 13.5, it is considered normal. And 12.5 to 13.5 centimeter, it is borderline malnutrition. And 11.5 onwards, it is acute malnutrition. And anything less than 11.5 means severe acute malnutrition. So the child will be suffering from kwashiorkor, marasmus, or marasmic kwashiorkor, different types of severe acute malnutrition the child will be suffering from if the mid upper arm circumference is less than 11 centimeter. Then we have head circumference. So here, occipitofrontal circumference is checked. That is the highest part at the back of the head, the skull region, that is occipit to the frontal bone. Okay, the circumference of that is checked. Chest circumference on both the nipples. Tape goes through both the nipples, on top of both the nipples, and that's how we get the chest circumference. And the measuring tape should be parallel to the floor. Skin fold thickness of the tricep muscles are checked by using Harpendon's calipers. It's a specific kind of instrument which helps you to, which will pinch some part of your skin to find out how thick it is. It also gives an indication of the subcutaneous fat which is deposited just under your skin as well. Then we have somatic quotient, in which the occipitofrontal circumference, mid upper arm circumference, everything is expressed in percentage form. Okay, and that is called somatic quotient. That means that 90% above or below 90%, so on. Then lower segment ratio. So the length of the upper segment is measured from vertex to the pubic symphysis. The ratio should be 1:1 by 9 to 10 years of age. At birth, it could be 1.7 to 1. The child will have longer upper torso as compared to shorter limbs. But as soon as the child grows on, the limb should have should outgrow the length of the thoracic cavity, that is from the vertex to the symphysis pubis, vertebral column of the neck to the end of the vertex to the symphysis pubis. So is it clear about the anthropometric assessment so far? Then we have mid-parental height and target height. So here, both the parents' height is required. Parents' height, father's height plus mother's height divided by 2. Okay, that's how you will get the male child's height. And plus 6.5 centimeter, you will get the average of the male child's height. For female child, again, father's height plus mother's height divided by 2 minus 6.5 centimeter. Okay, that's how you get the target height for the girl child. The growth monitoring and growth chart. A lot of growth charts we have gone through in our previous chapters. Okay, some similar are given in this chapter as well. We'll go through that later. Then age-independent anthropometric indicators, which means here age doesn't matter. Okay, just the physical indicators matter if the child is healthy or not. So in that you have the bangle test. In this, a bangle is slipped into the child's hand, forearm, okay, and the inner diameter of 4 centimeter up to the forearm, it will be pushed in. And if this bangle crosses the elbow, the child is malnourished. If the bangle does not cross the elbow, the child is not malnourished. So a bangle of 4 centimeter diameter should be used here. Next is the Shakir's tape. So here a plastic tape with colored zones like green, yellow, red, representing like 13 centimeter, 12 to 12.5, 13.5, 12 centimeter, 0.5 is made. So just by looking at when you measure the upper arm, when you look at the colors, you will understand if the child is malnourished or not. Then we have the quacker arm circumference stick. So it's a rod with 2 sets of marking, one indicating the height, the other indicates the mid upper arm circumference for the corresponding height. So every height, specific upper arm circumference has to be reached by the child. If it does not, it indicates that the child could be malnourished. Then we have modified quack stick. So again, this is also a rod which uses the color green, yellow, and red, and it represents normal nutritional status, borderline, or severe. Yeah, same. You have to. This rod is used to check the circumference, and if it is green, it is normal. Yellow means borderline malnutrition. Red means severe malnutrition. Then we have Navarro's thinness chart. So this chart represents expected weight for height as prepared by Save the Children Fund. And in severely malnourished child, the head touches the upper red zone of this chart. And if the child is coming under the nourished zone, okay, the chart will not be high, it will be low. Then we have mid-arm circumference to head circumference ratio. You calculate the mid-arm and then you calculate the head circumference. You divide it. So if you have an answer that is between 0.8 to 0.314, it indicates you will be having mild malnutrition. 0.25 to 0.27 moderate malnutrition, 0 to 2.4 becomes severe malnutrition. So calculate the mid upper arm circumference and divide it by the head circumference. You will get the ratio. And head circumference to chest circumference. If the ratio is more than 1, the child is normal. If the ratio is less than 1, means the child has malnutrition. And this is done in children who are above 9 months of age, because after 9 months, the head circumference will be slightly higher than the chest circumference. But as soon as the child starts walking out of their once the child starts walking, that is after 9 months or so, the chest circumference will slowly start to increase, and it will it will be staying in an increased size for the rest of the life, while the head circumference is comparatively smaller. Mid-arm circumference to height ratio. Again, calculate the mid-arm, divided it by the height. If you get an answer less than 0.29, it indicates severe malnutrition. If you're getting answer somewhere between 0.32 to 0.33, it indicates normal malnutrition. Then we have Rao and Singh's weight to height square. So when you do this, whatever is the child's weight is a numerator, whatever is the child's height is a denominator, height square. Okay. So the ratio, if it is more than 12.5, sorry, if the ratio is equal to 0.0015, it is normal. If the ratio is 0.0013 to 15, it indicates borderline. And less than, if the ratio is less than 0.013, it indicates severe malnutrition. That is Rao and Singh's method. So all these methods are not age dependent. Okay. Body mass index and Quotex index, that also we all know body mass index, how to calculate. For body mass, your age doesn't matter, just your height and weight. Okay. The mid-arm circumference that we have mentioned earlier, how to note it. Again, for mid-arm circumference, it is age independent. So classification of different types of childhood malnutrition. Tables are given. The same tables are given in the textbook as well. You can refer it later. Okay. Only some objective questions will come from this table. But since it will be an open book examination, you can still refer your book. So all the tables you can refer from the textbook. The same tables I'm going to show in the slide as well from different sources, but the content is same. So these are the different classifications of malnutrition. First is the Gomez classification. You don't have to remember all this. Make sure you have the textbook with you whenever you're going for consultation, etc. Have the textbook with you. And when you do the nutritional assessment, height, weight, mid-arm circumference, just you have to check when you're dealing with pediatric patients, okay, less than 5-year-old. You have to check this. So head circumference, chest circumference. It's the part of the check, okay? Only in pediatric nutrition when you're dealing with infants and toddlers. So this is Gomez classification. Weight for the age, if it is more than 90, whatever is the child's weight, okay, it is more than 90% of whatever is the age is, the child is normal, okay, it's not malnourished. If the weight of for the age, the mean average, whatever is the mean average, and if the weight comes in 75 to 89% category, it's mild malnutrition, and so on. And then we have Jellyfish classification. Again, similar, weight for age. For every age, there is its expected weight. And if you are 90% close to that expected weight, you are normal. Your nutritional status is normal. Okay. If you are 80 to 90% close, your first degree protein energy malnutrition is going on, and so on. PEM means protein energy malnutrition. Okay, so these percentages on the side are how close, how close are you to the ideal weight. Then we have Wellcome Trust classification. So in Wellcome Trust classification, the presence or absence of edema is important. Okay, just to make sure that if the child is just malnourished, the child has kwashiorkor or marasmus or not, or both or not. Okay, so the presence and absence of edema is noted in Wellcome Trust classification of malnutrition. Then Indian Academy of Pediatrics has also given a classification, grade 1, grade 2, grade 3, grade 4, again based on the weight for the age standard. In India also, there is a specific weight standard for every age, slightly different from the weight and age standards used by the global, at a global platform, slightly refined. Okay. So the same sources you will get from the textbook as well, the exact same sources. Then we have classification according to height. On table 26.6, if you have the textbook, table 26.6, you can see the degree of stunting. Okay, stunting means your height is not increasing as per your age. Okay, so if your height is 95%, more than 95%, closer to the mean average height of your age group, okay, the child's age group, then the child's growth is normal. Okay, if it is 90 to 95% close, then first degree stunting, and so on. If it is just 80 to 85 to 90% close to the average, okay, then it is second degree stunting. And if the child's height is less than 85% closer to the peers, it means the child is suffering from dwarfism. Then classification according to weight for height, table 26.7. Here wasting is given, okay. And this is the water loss classification which they have used. If there is no wasting and the height is normal, 90% close to the normal, it's considered normal. If there are wasting, whatever is the height of the child, but if the body is involved with wasting, it goes into first degree wasting. If the child undergoes severe wasting, severely, like the bones are also visible, okay. So in that case, it comes under the third degree wasting. So this is a table in which classification of weight for height, in which wasting, the grade of wasting is also analyzed. Then we have the WHO cutoff assessment of malnutrition in community studies. So it's 26.8 AC, that is a table. A to C. 3 different tables are given on page number 296. You can refer that. Again, malnutrition, different acute, chronic malnutrition. What is the level of stunting? What is the level of wasting? Okay, everything is given. So based on these three categories, you have to rate the child. Presence of edema. Okay, that is also given in the last table 26.8c. So these are the tables given by WHO for the assessment of malnutrition. Then we have the Z score. Z score charts are also used to interpret if the child is in the average score or not. Z score charts we have discussed previously. You can go for read that later. Based on height and weight. Next is the biochemical and laboratory test. So the test for these are the following tests that you have to do in a child to understand if the child is undergoing through any malnutrition or not. So serum protein level, albumin level, okay, enzymes like esterase, amylase, lipase, polymerase, okay, alkaline phosphatase, dehydrogenase. These are the enzymes you have to check. Check for carrier proteins like transferrin to see if iron deficiency is there or not. Ceruloplasmin to see copper deficiencies there or not, beta lipoprotein, essential amino acids are present or not, essential fatty acids, calcium level, serum calcium level, serum potassium level, phosphorus level, sodium level, iron, magnesium. So these all tests has to be done. Urinary creatinine levels also gives an indirect evidence of muscle mass. Alpha globulin level. So these are the biochemical and laboratory tests you have to do. Clinical features. The usual clinical features are like growth retardation, most common feature of malnutrition, where weight is lost, wasting will be there, stunting of the height is there, okay, and it's present in kwashiorkor as well. Hepatomegaly, enlargement of the liver, okay, because of too much of fat cells deposited onto the liver. It could lead to jaundice, it could lead to cirrhosis of liver as well, if not treated. Hair changes, color change, hypochromotrichia. Okay, the hair's color becomes lighter and lighter. Okay, it becomes reddish in color. Which is seen in kwashiorkor. Skin changes, dehydrated skin, dermatitis, easy rashes, redness. Then mucosal changes, inflammation, glossitis, tonsillitis, stomatitis are very common. Then purpura or bleeding because of vitamin C deficiency. She as well K deficiency, internal bleeding, internal coagulation, intravascular coagulation, which means within the blood vessels itself, blood clot will form. Instead of the blood keep moving forward, the blood clots will form. Then edema, that is swelling. It is seen in kwashiorkor and marasmic kwashiorkor, but not in marasmus. Mental changes, irritability, apathy is seen associated with malnutrition. Restlessness, regressment, no enthusiasm, playfulness is gone from the child. These are the mental changes. Then tremors. Tremors is trembling. Okay, like the child's hand will keep on shaking because the neuromotor function is it's not good enough to hold onto things. The child's hands, legs, feet, etc. will keep shaking. It may start with clumsy hands, but later it will be understood that it's tremors. It progresses slowly. Then we have dietary assessment. So three different forms of dietary assessments can be done. One is 24-hour recall forms. So in the past 24 hours, what all you have eaten, you make a list out of it and give it to the dietitian or nutritionist, whoever is taking care of your case. Okay, and once they start writing the recipes down, they themselves will be aware of how many empty calories they have been taking. Okay, so automatically that habit will also come to rest. Then food frequency questionnaire and checklist: how frequently you are eating food, what all foods you are having, what all do you take any extra or not, or etc. So that comes under the food frequency questionnaire. Then food records say even in food records, not just for one day, for an entire week or so, whatever the client has been eating will be recorded and it will be analyzed at the end of the week. If the dietitian is not giving daily one-on-one therapy sessions, then this works. Now, from the environmental and ecological assessment point of view, the physical environment health is, we say that it's the well-being of the physical, mental, and social areas of the patient. So all these environment also should be healthy. Okay, like the physical environment, it should be noise free. Water, soil, climate pollution should be down. Radiation should not be there. Heat and light pollution should not be there. So it is viable for the humans to live a healthy life in this environment. Biological environment to see all the living things living around the human being or the child, microbes that are around the child in the washroom, on the body. Okay, and in some cases, your body's own microbe can infect you. So this should not be the case with the child. Then we have psychosocial environment. Okay, it's personal health, emotional health, the dynamic between the parents. Okay, customs, habits, attitudes, beliefs, morals that develop at family. Okay, lifestyle. So this all impacts your psychosocial environment. Microenvironment at home. It also has all these factors: physical, biological, psychosocial. All these factors are found in microenvironment as well. Mother and child unit, parent-child unit. Okay, family unit. These all are microenvironment. What happens within the home? Okay, home is a microenvironment. Then you have the 10 commandments of environmental health. Simple statements like have safe drinking water, dispose of excreta safely, proper disposal of all waste, dry waste different, wet waste should be different, pollution control, noise reduction, proper housing standards, proper ventilation, right lighting, prevention of radiation exposure, control of any biological hazards like spread of infection, outbreak prevention, and all the legal measures for all these statements above follow that. So these are the 10 commandments of environmental health. Assessment tools: socioeconomic status, sanitary condition, housing condition, microenvironment. They all can be assessed by a professional who can visit the home and take a check of all these areas. Then you have the vital statistics and health indicators. It's epidemiological studies that give you insight on infant mortality, morbidity, maternal mortality, morbidity, stillbirth rate, okay, under 5 mortality rate. teenage pregnancies. Okay, these all epidemiological data will be collected from all the national health department and policies are made against it. Then we have the functional assessment, functional evaluation. The first is your neurodevelopmental indicators of malnutrition. So if a child is malnourished, there will be a delays in muscle mass, electrolyte imbalance, okay, hand grip strength, psychosocial deprivation. So these are the indicators of delay in neurodevelopment. Morphological indicators, you can take a buccal smear and you can see how many cells are healthy, how many cells are mutilated. So if there are too many cells that are mutilated, which is broken, means the child is malnourished. Okay, so that's a morphological indicator. If the child has curly hair, it may straighten up if the child is malnourished. In the hair root, the mineral content may reduce. Difference in the hair texture can be seen, and that is an early sign of malnutrition. Special sense organ function, like night blindness, cirrhosis of the conjunctiva, can happen as an evidence of vitamin A deficiency. Tiredness, pallor. Pallor means lack of luster in the skin, pale skin. Okay, that is seen in iron deficiency anemia. Infantile tremor is seen in vitamin B12 deficiency. These are few signs and symptoms seen in special sense organs to identify any deficiency due to malnutrition. Then we have radiological indicators of malnutrition. Osteoporosis. How you can check osteoporosis? You have to see the X-ray. When you do the X-ray of these children, you can see the retardation of the bone age, osteoporosis, rickets, evidence of rickets, bow-shaped legs. So during these radiological studies, you can identify if the child is malnourished or not. Coming to growth monitoring, from birth till the age of 5, vigorously you have to monitor the child's growth, all the milestones have been achieved or not. So that comes under the major part of the growth monitoring. So up till the kindergarten age, preschool age, vigorously you have to monitor the child's growth and milestones. So it gives you, it's a really good intervention when you monitor the child's growth. If there is any deviation, if the child is delaying to reach its milestone, that could be an indicator of, early indicator of malnutrition, which can be corrected without it leading to much damage. So that's about all the nutritional assessment done.